I want to make 3 points about health inequality and population health today. The first is that the US population is sicker, on average, than all other populations in rich democracies. That is, depressing, but not all that surprising, perhaps. I think a lot of folks are relatively familiar with this point. Less familiar, maybe, are the 2 subsequent points that I want to make. First of all, that the US has a higher level of social inequality in health than other rich democracies. So not only is the US not as healthy as other rich democracies in terms of the broad-scale mortality and morbidity measures that we're accustomed to looking at, but there's also more social inequality in those measures in the US than there is elsewhere. Third, and maybe most provocatively, the health of many states in our union resembles more than anything else the population health profile of several former Soviet nations. So that may be the most shocking news, and I see that certainly as the bottom line of this presentation. You walk away leaving, what was this presentation about? This presentation was about how population health in the United States, in many of the states in the US, resembles former Soviet nations. So this is the first little piece of evidence that I want to show you. This is on aggregate average population health in the US. And these numbers are relatively familiar. This kind of news regularly comes up in public discourse. Some of you may have seen a paper last year by Ann Case and Angus Deaton that was on population health differences cross-nationally and how the US was really a laggard in population health as we seem to be in so many things. But I think it's worth it to renew these numbers just so we see the broad-scale aggregate average numbers that we're talking about, right? And so what I show here is the top 8 countries on life expectancy in 1970 and then later in 2010. And then I show where the US ranks on life expectancy in 1970 and 2010. You can see that in 70, the US ranked 15th. By 2010, the US had slipped to 25th. And again, this is average population health as quantified by life expectancy, which is basically a weighted averaging of mortality rates across all of the age ranges in the population. And so it's a highly synthetic measure, right? A little bit less synthetic a measure is the infant mortality rate. So the percentage of, actually not the percentage, but the number of infants who die before the age of 1 for every 1,000 live births, right? So this is the infant mortality rate again for 1970 and for 2010. And you can see, this is not that far off from how the life expectancy rankings looked for the same period. In 1970, the US was 16th at infant mortality rate of 20. By 2010, the US had dropped to 29th and had an infant mortality rate of 6.1, right? Pretty far off where the leading nations seem to be in terms of average population health. So this is the big picture, right? But drill down a little bit, and there are really 2 problems, at least 2 problems with aggregated, averaged figures like these, like the life expectancy and like the infant mortality rate. First of all, the US is a lot larger than a lot of these other countries that we're talking about, right? Particularly when you're talking about Scandinavian countries, you're talking about countries with a population between 5 and 10 million, right? Really small, okay? And so we should look at what's going on at the state level, right? The second problem, and more deep and thornier in many ways, is the problem that these aggregate average figures really overlook the massive amounts of inequality that may exist, right? Because the first moment of the distribution, the average, can go along with the second moment of the distribution, the standard deviation or the variance, right, in many different ways. You can have a population health profile that looks pretty good and has a really high amount of inequality around it, right? So you've got like a central tendency that looks pretty good, but then you've got a really wide spread, right? You can have the same level of population health that has a lower spread around it, right? So when thinking about population health as a phenomenon that characterizes an entire population, you have to maintain this view of the average and a view of the spread at the same time, right? And life expectancy and mortality rates really don't let us do that very well. So what my co-author, Katie Morris, and I do is to disaggregate population health into the 50 United States separately, plus the District of Columbia. We also compare the 50 United States in our report to 27 EU nations that have data available from the European Union Survey of Income and Living Conditions. And so, this slide shows you some details about the data that we use. For the US, we use current population survey data. For the EU, as I mentioned, we use the EU SILC. We've got roughly 500,000 observations from each of those data sets, and so we can come up with relatively precise estimates at a disaggregated geographic level of analysis, right, for states and for smaller countries. We measure health inequality using two different relative measures. One is the relative risk ratio, which is the percent of the poor in poor health over the percent of the non-poor in poor health, basically like how much more likely are you to be in poor health if you're poor, right, versus if you're non-poor. But we also use the incident rate ratio, which allows us to introduce a number of different controls. The reason we do that is, of course, that the European population differs in lots and lots of ways from the US population, and so it's very important to take into account those kinds of differences, right? What am I talking about in terms of population compositional differences for the EU versus Europe? First, I'm talking about the fact that on average, the EU population is about 5 years older than the American population. Another important fact is that in the US, the average level of educational attainment is actually quite a bit higher than it is in Europe, right? And so we need to adjust for these differences. Now, you may already be wondering, like, wait a minute, those things would seem to indicate that health should be worse in Europe, right? Not better. And so, you kind of see where I'm going with this, right? The relative measure that we calculate for income inequality, they both use the bottom 20% of the income distribution as our quote-unquote poor group. We're just using this label as a way of simplifying the language, right? We're using the top 20% of the income distribution as being non-poor, right? And in both of these surveys, the income measure that we're using is disposable household income, so the after-tax and transfer and in-kind contributions that people have already talked quite a lot about today, okay? So, what do we find? We find a lot of multicolored dots. So what's going on here? I've tried to indicate the key findings here by chopping up this figure into 4 quadrants, right? So these are 4 different kinds of states. On the top left, you have equally unhealthy states, right? States that have a higher than median prevalence of poor health, right? Because this is based on responses to individual level survey data that ask people to rate their own health. And you also have a lower level of inequality in health on the basis of income, right, than the median, okay? So that's the equal unhealthy group. Going around the figure in a clockwise fashion, you then have the unequally unhealthy group, right? So a higher level, higher prevalence of poor self-rated health, and also a higher level of difference between the non-poor group and the poor group in terms of health, right? And then on the bottom right, you have the unequal healthy group, where you have pretty good population health, right, relative to this distribution at least, but that health is more unequally distributed than the median, right? And then the lower left quadrant is the equally healthy group, right? And one of the things that strikes me about this figure immediately is the overall spread of the observations, right? Like if you look at this figure, you can see right away that there are not very many states that are in the equal healthy group. And the ones that are in the equal healthy group are kind of like barely into the equal healthy group, right? They're just a little bit over those median lines. They're all compressed together. You can't really tell which state is which. There is a very large number of unequal, unhealthy states, right? And so we've color-coded these by geographic region of the US. The unequal, unhealthy states tend to be southern states. There are also a few Midwestern states, right? So Tennessee, Alabama, Kentucky, Mississippi, Louisiana, Ohio, Indiana, places like this, right? And then there are also some places that are very, very unequal, but also particularly healthy, right? Massachusetts, the state where I live, is a state that's famously in that group, right? We have reports by the public health agencies all the time talking about this inequality and what can be done about it. It's a very well-known fact for Massachusetts. And then also you've got some equally unhealthy states, right, where the overall level of health is not particularly good, but at least everybody is equivalently sick, right? Not really sure those are great places to be either. All right, so this is the basic story for the U.S., and I should mention that these red lines are at 5 and 13%. What does that mean? That means that the median level of health inequality for a U.S. state is at 5, meaning that if you're poor, you're 5 times as likely as the non-poor to report being in bad health, right? Which is a really big effect. And the level of the prevalence of poor health in the U.S. is 13%, so pretty high, right? We only know it's high because, turning to the next slide, I show you the data for the European Union, right? So here, I follow the same organization of the figure, right? Equally unhealthy, unequal, unhealthy, unequal, healthy, and equal, healthy. And you see here that there's a difference in the prevalence, right? So the prevalence of poor health in Europe is lower, which isn't surprising given the broad scale average life expectancy and infant mortality rates I showed you, right? What's a little bit more interesting is that the median relative risk ratio is about the same, right? So in terms of your income, right, controlling for nothing else, taking absolutely nothing else into account, not accounting for age, not accounting for education, not accounting for anything else, right? There's still a pretty big poor, non-poor gap, right, in terms of reporting poor health in the European Union, right? And so, I want to note, turn back to this figure. So the unequal, unhealthy U.S. states are places like Mississippi, Alabama, Kentucky, Tennessee, Louisiana, right? In Europe, the unequal, unhealthy states are Estonia, Slovenia, Latvia, Bulgaria, Czech Republic, right? So those are the peer European countries for the American states that have a low level of population health, but also a high level of health inequality, right? One of the striking things about the figure, I think. Now, there are 2 problems with this. First is that because of the way the questions were asked in the EU Silk and in the current population survey in the US, these data were never meant to be compared side to side, right? And so we're putting different categories of responses together when we look at this health question. So in the US, the way that it's worded is your health poor or fair? Those are the 2 non-good health groups, right? Whereas in Europe, the 2 categories that we match those to are very bad and bad, right? Obviously, there's a qualitative distinction between the meaning of those designations, right? And so the way that we've dealt with that, and you'd have to read it in the report. I don't have time to get into this part of it in the presentation because I'm trying really hard to stick to my allotted 15 minutes. David, I'm trying really hard. The way that we dealt with that was to look at different health indicators, limiting long-standing illness, for instance, and limitations on the activities of daily living. And so you can have a look at the report for those. But what I do want to highlight in this talk is the role of compositional differences in the US states versus the EU member states, right? So we know that these populations are different, they're heterogeneous in different ways. We also know that lots of other stuff shapes someone's self-rated health aside from their income, right? And so it's really important to control for these other factors and see what the remaining role of income is, right? So that's what we do in these figures. And this is the incident rate ratio that controls for all this stuff, right? So you should interpret these bars as how important is having income for your health, net of many of the other factors that are important for health, right? Like age, unemployment, sex, marital status, education, right? Those are the 5 things that we control for. And what this does is basically gives you a league table, right, of US states that are grouped by region. And one thing that jumps out right away is that the incident rate ratio controlling for all this stuff for the US is about half as large as it was in the data that don't control for anything, right? So a big part of the health inequality that we saw in the earlier figure is a function of all these other things, right? And once you control for all these other things, then you still find that the poor are about 2.5 times more likely to report bad self-rated health than the non-poor, right, in the US, even net of everything else. And interestingly, again, there's really quite a huge spread, right? So this varies from, a low of 1.8, say, to a high of 4.5, right? Again, Massachusetts standing out. So it's not the case that, the poor are always unhealthy to an equal degree, right? And the rich are always healthy to an equal degree. There's nothing particularly natural about that kind of inequality. That kind of inequality is something that's systematically variable, yeah? So, turning to the Europe data, we can see here, what jumps out first is that the incident rate ratio controlling for all these other factors that are important for reporting your self-rated health goes down by quite a lot more in the US, right? So here, the incident rate ratio controlling for all these other factors drops to about 1.7, right? So much less income-related health inequality in the EU after accounting for all the other stuff than there is in the US, right? It's a rate ratio of 1.7 compared to a rate ratio of 2.3, right? Pretty big difference. In other words, if you were to put these bar charts together, right, in almost every US state, you would find a higher level of income-based health inequality than you would find in European countries, right? So really, really big difference. With that, I'll conclude by just reinforcing a few things from the main points I wanted to make. So the US population is sicker on average than populations in rich democracies. The healthiest states are really quite a disparate lot, right? New Hampshire, Minnesota, Nebraska, North Dakota, Utah. The healthiest countries in the EU 27 are Denmark, Iceland, which we've seen on several of these bar charts that have been presented today, right, as performing pretty well overall, but also Malta, Netherlands, Sweden. Second, the US has a much higher level of social inequality and health than other rich democracies, right? So the most unequal US states are Connecticut, Indiana, Massachusetts, Michigan, Tennessee. The most unequal states in the EU 27, after controlling for these things, Cyprus, Estonia, Malta, Netherlands, the UK, right? And really crucially, controlling for all of these compositional differences between the US population and the EU population, the US is much more unequal than the EU population, right? And third, and most surprisingly, I think, the health of many states in the Union, if you just look at the raw number of people who report being in less than good health, right, and the income comparisons and the role of income in making those comparisons, what you find is that there are many unequally unhealthy states that resemble nothing more than former Soviet and Soviet ambit countries, right? Which I think would come as quite a shock to people living in Alabama, Kentucky, Louisiana, Mississippi,